So good afternoon, and thank you for your welcome. And I would like to address the question, how can we respond to the challenges, the huge challenges which face us in our healthcare systems of providing high quality care, continually improving care, and compassionate care for people in our communities? And not just to answer that question or address that question, but to also address the question of what can we individually, day by day, do which will make a difference? What can we individually do, day by day, in our interactions which will make a difference? And the starting point for me is to reflect that in seeking to respond to the challenges that we face, that we are damaging the health and well-being of the very people we ask to deliver care for people in our communities. So we know when we look at results of stress surveys among staff in countries like Ireland, like England, other OECD countries, that significant numbers of staff every year report being unwell as a result of stress at work during the previous year. We know that something like 50% more of those who work in healthcare have debilitating levels of work-related stress compared with the general working population as a whole. And we know not only is that hugely paradoxical in terms of we are seeking to create systems which promote health and well-being, but we're damaging the health and well-being of those who provide care within those systems. It affects their longevity, it affects their family relationships, but it also affects quality and safety of care. We know that high levels of stress are associated with higher levels of errors made by staff, poorer care quality. It's more difficult for people to offer compassionate care when they themselves are under stress. And we know that in the hospital sector, in the acute sector, it's associated with subsequently higher levels of patient mortality. And it doesn't need to be that way, because we know that there are some healthcare organizations that have been successful in reducing levels of stress and sustaining them at a low level. So what are we to do? How are we to respond to that fundamental issue which feels paradoxical at the heart of our healthcare systems? Does this chime with you? Is this something you recognize? So I think we have to go back to the heart of what our healthcare systems are all about if we're to address this question. At core, what are our healthcare systems are about? And when they've been set up and as we seek to develop them, the aim is that we're going to deliver high quality care to everybody who needs it, regardless of wealth, status, prestige, background. An inclusive, compassionate system. It really matters in our society because our healthcare systems are an expression of our core national values of compassion. And so healthcare is constantly in our newspapers, in the media. We're discussing these issues constantly because we're fiercely protective of our healthcare systems. We want them to be an expression of our core national values of compassion. And all of you and everybody who works in the Irish healthcare system, you've made a decision at some point to dedicate an enormous part of your precious, unique, mysterious, magical lives to the care of your fellow human being, to the people of your communities. So you too embody a core work value of compassion. Compassion, it's one of those soft, lovely words. For me, it's the healthcare assistant I saw staying for an hour after her shift had ended, holding the hand of an elderly lady who was in distress and talking to her lovingly and caringly until she was calm again. It was the general practitioner in Southwark who told me that she had danced in her surgery that day with a lonely elderly man when she discovered they had a shared interest in dancing. Beautiful, eh? Beautiful. And I'm sure you see and model examples of compassion every day in your work life. But I think it's important to understand also what it means in behavioural terms. So if Colette here is in distress, this is quite safe, Colette, I promise you. If Colette is in distress, then for me to be compassionate, firstly, I have to pay attention to you. I have to be here and now with you. To use Nancy Klein's lovely phrase, I have to listen with fascination. And second is I have to arrive at an understanding of the causes of your distress, ideally in a conversation with you if we can. And third, I have to have an empathic response. I have to feel your distress, because that gives me the motivation as well for the fourth step, which is asking the question, how can I serve you? How can I help? Make sense? Those 4 steps? Attending, understanding, empathizing, and helping or serving. Do you feel better? And when healthcare staff deliver compassionate care, we know that patients and service users are much more satisfied with their care. And that in turn, we know, has an impact on staff well-being and commitment. So the challenge for us is how we create cultures in our organizations where compassion is the norm in all interactions, how we create cultures of compassion. And nurturing cultures, shaping cultures, the most malleable, powerful influence that we have over cultures is leadership. So in order to create cultures of compassion, our leaders have to model compassion in their leadership. And that means leaders who pay attention to staff, first and foremost, who listen with fascination. One of the complaints I hear from healthcare staff continually is, we never see our leaders unless something has gone wrong. So it's listening with fascination to staff. Second, it's understanding the challenges that they face, ideally through a discourse, because the understanding then will be both more accurate and it will be shared. And third, it's leaders who feel for staff, who feel for the difficulties, the overwhelming challenges that they face. And then leaders who ask the question, how can I help? How can I help you to do the job that you want to do, to deliver high quality, continually improving and compassionate care? After all, that's what the role of leaders is to create the conditions to help those they lead do the job that they and we want them to do. Another complaint I hear from staff is, well, some of our senior leaders do come and listen to us, and they're really good at listening, but nothing ever changes. So it's about leadership that attends, understands, empathizes, and serves or helps. Make sense? So I think that's something each of us can do every day in the way we behave within our organizations in relation to those we lead and in all our interactions. And that's it. That's mainly what I wanted to say. But one other thing that's come out from the research I and colleagues have been doing, that I've had the privilege of being involved in, is when we look at high-performing healthcare organizations around the world and the research literature which looks at the climates and cultures associated with high-performing healthcare organizations, what we see is that command and control is about the worst form of leadership culture for high-performing organizations. Because after all, in these contexts, what we have is highly skilled, highly motivated staff. Why would we adopt a leadership model of command and control? By the way, the national organizations in England, notice that there are 12 that oversee the functioning of the NHS. that tells a story in its own right about difficulties of compassionate leadership, have sponsored a new national framework, which was published in December, focused around collective, compassionate, and inclusive and effective leaders at all levels, as well as knowledge of improvement methods. And they have committed to modeling compassionate and collective leadership in the way they work within the system. And I was delighted to note that last week the HSC north of the border here also published their new leadership strategy focused around collective and compassionate leadership. Collective leadership means moving from a leadership style where people are dependent and there are those in authority, not adopting a leadership style where we simply have heroic individual leaders, but moving towards a leadership style which is truly collective, where it's a collective activity. And understanding what collective leadership means, I think, involves an appreciation of 4 elements. First of all, collective leadership means that everybody sees that they have leadership responsibility and welcomes that. It's the junior administrator I saw who presented to a large London conference 2 weeks ago the quality improvement initiative from their team. It's also, collective leadership is about shared leadership in teams where leadership shifts depending on the expertise of individuals within the team and the task at hand. It just seamlessly shifts rather than directive top-down leadership. It's leadership where leaders are prioritizing patient service user care overall, not just their individual areas of responsibility. And leadership where there is a consistent approach to leadership, of positive, supportive, compassionate leadership. It's no good if, you have, what's your name? Connor here in one department who's this warm, supportive, positive, compassionate. His colleague is nodding. Leader, and in the next department you've got Colette, who's this demonic, despotic, punitive leader. We have to have a consistent style of leadership across our organizations. And I must say, personally, I'm really delighted to be working with Ailish McAuliffe in UCD on how we can develop collective leadership across the healthcare system in Ireland. It's a real privilege for me. So we need to move more towards these models of compassionate and collective leadership. We also know quite a lot now about the kind of key cultural elements that need to be in place for the delivery of high quality and continually improving and compassionate care. And what that then implies is that our leaders must focus on these areas. If these are the key elements that need to be in place in our organizations, then that means these are the most important areas that leaders should be focusing on. And I want to describe each of these areas briefly to you. And you'll see links on all of the slides, and I hope that everybody will have access to the slides so that you can pick up on the links and follow through the sources and the tools, which I'll show you later. The first is the importance of an inspirational vision, that actually people really need to be clear about what their organization's purpose is. And in healthcare, that's about focusing on high quality care, continually improving care, and compassionate care. And you'll see here the kind of vision or mission statement of the Department of Health. But the point is, this cannot simply be a bunch of words on the website. That visions and mission statements and statements of values have to be embodied by leaders of organizations every day in their leadership working. Otherwise, they're more likely to corrode trust and commitment in the organization. So hopefully, the leaders in the Department of Health are thinking every day about improving what can I do to support those I lead to improve the health and well-being of people in Ireland. And this is important because there is a danger in the current discourses, certainly I see it in England, where I'm doing a lot of work, that what we are doing is our leaders are spending time talking about, monitoring, focusing on, rewarding, punishing issues to do with financial performance. And so it feels like financial performance becomes more important than quality of care. And what that does is send signals to staff about what leaders truly value and truly feel is important. And we know from some of the awful case studies that we've seen that that is a slippery slope towards poorer and poorer quality of care. So what leaders talk about, pay attention to, and monitor must reflect what the core purpose of the organization is. Does that make sense? Second, it's about making sure that we then translate those purposes into effective performance. And we know from the work we've done in many healthcare organizations that when we observe what's happening in them, we find that there are lots of priorities. We've come to call them the priority thickets. They begin with the national organizations setting priorities, then the executive teams set priorities, directorates set priorities, and there are so many priorities that no one can see what's important at the front line anymore. So we hear staff saying, well, all of this stuff comes down and I just try and get on and give high quality care to the people of my community. We also know from the last 60 years of research on human motivation and performance at work that, rather banal, I suppose, but the most important determinant of people's performance is whether they have a limited number of agreed, clear, challenging objectives for their work. And the same applies to teams, that teams, healthcare teams, are most effective when they have a limited number of agreed, clear, challenging objectives aligned to the mission of the organization. It begins with the executive team and applies to every team throughout the organization. Because when people are overwhelmed with targets and objectives and priorities, many of which they've not agreed, their role is less clear, mistakes get made, and there is much less efficient performance. So it's a really important discipline to ensure that we're aligning agreed, clear, challenging objectives with the overall purpose of the organization. And those objectives should relate to issues like care quality, patient safety, quality improvement. In the case of teams, every team in every healthcare organization should have as one of its 5 or 6 objectives improving the effectiveness with which we work with other teams in the delivery of care. But we must also work really hard to ensure that all of this data that we collect within our healthcare systems is used to inform people who are delivering care about the extent to which they are meeting those objectives. Otherwise, why are we collecting all of this data? Other than to feed some mythical beast somewhere. Make sense? You with me? And the third point I can sum up by saying, if we want staff to treat patients with respect and care and compassion and dignity, we have abundant evidence that we must also treat then staff with respect and care and compassion and dignity. So we've been running a staff survey, as Colette said, since 2003 in England. All healthcare organizations must complete it. What that data has enabled us to do is to see how, from the perspective of staff, our health service is changing over time. It also enables us to identify those organizations that are doing particular things well, like staff engagement, or the quality of appraisals, or discrimination. We can look to see the good examples, but most importantly, what it's enabled us to do is to link staff experience to patient outcomes over time. So we're able to see the association between, I'm trying to go one forward. If you can move me one forward at the back, please. So while somebody's sorting that out, what we're able to see is that staff experience is linked to patient experience. What staff say about their leadership predicts what patients say about quality of care. You with me still? And that when staff say they're under high work pressure, patients in hospitals say there are too few nurses. They're not treated with the respect and the dignity that they require. When staff report poor health and well-being, high levels of stress, what we see is that subsequently audits of care quality in those organizations indicate significantly poorer care quality. In the acute sector, higher levels of patient mortality, and actually really clear indications of worse financial performance. Links between quality of care and quality of staff experience and patient outcomes are really clear. Hooray, we're back. There's a link there at the bottom. We just have such clear evidence about these associations over time that the case is clearly made. And so what that requires is that we have leadership that reflects an understanding of the importance of how we treat staff. For any of you who are eager to take pictures and worried about getting the presentation, I will happily send them to you if you email me, and my email address will be at the end. So that means that we need leaders with a particular leadership style, ideally leaders who are authentic, who are genuine in the way they interact, leaders who are open and honest with those that they lead, who are transparent, leaders who are full of curiosity about how to lead better. Leadership is not a finished product. It's about leaders who are always asking those they lead, how can I help you more effectively? What should I be doing more of, less of? Leaders who are optimistic, positive, giving people a belief in a positive future. Leaders who are appreciative. One of the key complaints, again, that we hear is from staff is they say nobody ever comes and says thank you. There's patients do, but our leaders don't. And finally, leaders, as I've said, who are compassionate. So I want to move on again 2 slides, if you can help me. There we go, thank you. The measure in our staff survey, which is most powerful in predicting outcomes, is the measure of staff engagement. It trumps everything else that we look at. And we know that staff engagement is predicted from the data we have by supervisor support, team working, work pressure, very high work pressure, lower levels of engagement, feeling valued by colleagues, and so on. And it doesn't matter what organization type we look at, staff engagement is the best predictor of performance, whether it's mental health trusts, organizations, community care organizations, ambulance delivery services, or hospitals. The same results apply. In the acute sector, it predicts care quality, financial performance, staff absenteeism, patient mortality. It's a really important determinant. So we're also able to say a little bit about those organizations we've seen which have raised levels of staff engagement and sustained them over time to synthesize out what are the key characteristics that they seem to embody. The first is that they're organizations that have this clear vision and strategic narrative. We've talked about that already. It's not just a bunch of words on the website. It's the way that leaders behave by focusing on that vision throughout the organization. Second, these are organizations that have adopted an approach of retraining all of their leaders to adopt more participative, supportive, if you like, compassionate leadership styles, not simply by sending people away on training courses, but by building a leadership culture within the organization through coaching and mentoring and peer support groups and action learning groups, so that there is a consistency of style, so that Connor and Colette are behaving very much the same way. Quite different personalities, but the consistent style of leadership behavior. And it's also, these are organizations that have devolved responsibility for quality improvement down to frontline staff, not just by advocating that they make quality improvement part of their job, but by giving them the training and the time and the resources so that quality improvement genuinely is part of their skill set. So Wrightington, Wigan and Lee, which is a hospital on the northwest coast, has partnered with Unipart, which is a car parts distributor, to adapt lean techniques and train staff in the organization. And there are 350 quality improvement champions in the hospital. And at any one time, there's 150 quality improvement projects going on. But they've given people the skills and the time and the resources and the freedom to make a difference. And fourth is that these are organizations where there is a high level of trust, that staff perceive that the organizations work in fair ways. And actually, if you look at the international research literature on engagement, not just in healthcare, but in other organizations, trust is the most important predictor. The more there are perceptions of unfairness, inequalities, discrimination, the worse, the lower the levels of staff engagement. I think staff engagement is as important as medication errors, as important as clean wards, for example, in the delivery of care. And we should be publicizing the results of staff engagement surveys in all our organizations because it's important, transparent data for patients and the public. And the fifth one there is about the stability of senior leadership. Anyway, I went to Wrightington, Wigan and Lee at some time ago now to their engagement committee meeting to learn about how they had lifted levels of engagement, and they kept talking about the horse. It turned out there was a patient on the palliative care ward with just a few hours left to live. Her name was Sheila Marsh. And one of the nursing staff asked her if there was anything she wanted in the last few hours. And she said, I would just really like to see Bronwyn again. Bronwyn, it turned out, was the horse she'd raised from a foal during her time working at Haydock Park Racecourse. So the nursing staff got in a huddle and picked up the phone and called the family and said, can you bring the horse into the hospital? And the family organised a horse box, and Sheila Marsh was wheeled out into the car park. And this is a picture of the horse clearly recognising her and nuzzling her and kissing her. And it was a really moving moment, captured on a camera phone, seen by many people around the world. It was really moving for Sheila Marsh, really moving and for her family also. And actually it was really moving and affirming for the staff also in the organisation. Nobody called health and safety. Because there was a culture of compassion and engagement, staff did the right thing and they were supported. So it's about how we create these cultures of compassion and engagement in our organizations. And that's about how we lead and how we interact with each other. And it's also about making sure that we create positive environments. Do you know, understanding health is about understanding the role of positive emotion in human health. If you take the top 10% of the population in terms of levels of positive emotion and the bottom 10%, there is on average a 10-year longevity gap between them. We understand that positive leaders of healthcare teams create more cohesive, optimistic, positive teams that deliver more compassionate care. Positive behavior is enormously important in human behavior. If you induce, are there any doctors in the front? Any medics in the front here? Raise your hand. Any medics here? Yeah, Connor, do you like chocolate? You do like chocolate, yeah. So just before Connor diagnoses you, if you give him a bar of chocolate, he will make better medical diagnoses. There's really good, clear evidence about it. What's your colleague's name?
Oscar.
If we give you a bar of chocolate, do you like chocolate? Oh, good. If we give you a bar of chocolate and then expose you to the cold virus, you're much less likely to contract a cold. So we can go on with this. But the point is that there is enough negativity in the context of healthcare, death, fear, pain, anxiety, lack of control. We don't need to be adding to it unnecessarily as leaders in the way that we lead and manage. It's about creating positive environments by authenticity and openness and curiosity, as I described earlier. But it's also about recognizing that negative emotion is really important in these contexts as well, that terrible things happen, that staff members become terribly upset. I was at a mental health trust recently where there was somebody took their own life, one of the service users. It's devastating for staff. And we have to create spaces within which it's possible for people to come together and talk about, legitimate, validate the negative experiences that occur in healthcare as part of creating positive, healthy environments. And the introduction of Schwartz rounds, do any of your organizations use these Schwartz rounds? Just nod vigorously if you do. Yes, it's a bringing together of people, usually over lunch, it could be 50 or 100 people, to talk about often negative experiences that have happened and to give staff the space to share these experiences together. And it's also, I'm not advocating that what you have to do in terms of positivity is come to work on a Monday morning as some kind of frenetic comedy clown character. It's about authenticity and openness and curiosity and compassion. Make sense? And the fourth principle is the importance of learning and quality improvement and innovation. I was talking 2 weeks ago to a medic who had just brought down the waiting list for bone density clinics from 18 weeks to 1 week for the wait, just by simply addressing the flow problems and being committed to making sure that the delays would be ruled out. Talking to Cheshire firefighters who in their safe and well visits to inspect the homes of elderly vulnerable residents have partnered with the local healthcare system and now have handheld ECG devices to take the pulses of elderly patients, to identify those with irregular pulses who might be at risk of strokes. And in 9 months, they've identified 27 people with that vulnerability who could then be taken into the system and supported. It's developing ideas for new and improved ways of doing things. That's the only way we're going to respond to the challenges which face us, is innovating. Finances are vital, but on their own won't be enough. And we know a little bit about the kind of factors that are associated with innovation and improvement in our healthcare organizations. We recently produced a report in the King's Fund called Caring to Change, based on a review of all of the literature on innovation and improvement, and particularly in healthcare. What we've concluded is that healthcare organizations often focus on skills and processes like quality improvement processes, but tend to neglect some of the wider organizational cultural factors which are essential for innovation. I had the privilege of first starting to do research on innovation in healthcare back in the 1980s, looking at the experience of student nurses, bright, committed, motivated people, placed in a situation where they had no freedom whatever, and the turnover was 35 to 37%. All of the work we've done since reinforces the importance of autonomy, giving people the time and the space and the freedom from hierarchical rigidities to be able to develop ideas for new and improved ways of doing things and implement them. So this issue of collective leadership and creating autonomy is vital for encouraging innovation. And it's also about making sure that we're providing support. One of the key factors inhibiting innovation is simply workload. We know that there is an inverted U relationship between workload and innovation and improvement. Very low levels of challenge in your work, low workload, you get very little innovation. Moderate to high levels, much more innovation. Very high levels, no innovation, because people simply don't have the time and the headspace and the resources to develop and implement new and improved ways of doing things. So as leaders, we have to address these issues of excessive workload, because otherwise we're creating the conditions where there won't be innovation. And so it's really vital that I think that as leaders, we are sensitive to where the hotspots of high workload are in our organizations and address that issue. And it's also about listening to all voices. We know that innovation and improvement happen when we listen to the voices of all professional groups, when we listen to dissenting voices, when we involve minority groups in our organization and hear their voices that are often stifled, discriminated against groups. And also, as was said this morning, the voices of patients, not simply in empty consultation exercises, but as truly influencing the design and delivery of healthcare services. And it's about team and inter-team working, which I'll come back to. And central to all of this, we've discovered, is compassionate leadership. Where there's compassionate leadership, then what that does, with compassionate leaders focused on staff and focused on high quality care, that reinforces the intrinsic motivation and fundamental altruism of healthcare staff. It's more likely to create the conditions where staff will take risks to try new and improved ways of doing things within safe boundaries, recognizing that not all innovation will be successful. Compassionate leadership seems to create the conditions of psychological safety within teams. It's a term that Amy Edmondson at Harvard, who studies healthcare teams, uses. And what psychological safety does is creates the conditions where people will speak up about errors, problems, concerns, issues. And it also, compassionate leadership seems more likely to create the conditions that empower people to develop and implement new and improved ways of doing things. And we know also that in teams, what it creates, compassionate leadership is associated with higher levels of cohesion and optimism and efficacy, which is associated again with higher levels of innovation. Make sense? And the fifth is the importance of team working. I mean, it kind of feels a little bit cliched to be talking about the importance of team working in healthcare. We have so much evidence and so much data about how important team working is. And we have quite a lot of understanding about the key elements for effective team working. Sure, those will be familiar to all of you. However, our evidence is that in the healthcare system in England, and from some of the discussions I've had with Ailish and colleagues, we think that there may be similar issues in some organizations in Ireland. The quality of team working in healthcare in England is really pretty sloppy, pretty poor. So 95% of staff in our system, 1.4 million people, report working in a team. We're not really sure what the other 4 or 5% do, but anyway, they say they don't work in teams, but 95%. And then we say, does your team have clear shared objectives? Do you work closely together to achieve those objectives? Do you meet regularly to review your performance and how it can be improved? And the figure then drops to 40%. So we've got 40% we think work in real teams and about 55-60% working in what we would call pseudo or dysfunctional teams. Here's some data on patient safety from the acute sector, looking at errors and stress and injury. The bottom right, what you have is the group of people who say they work in what we would call a real team. On the left-hand side, those not working in a team. And then going up from bottom right to the top left, it's those who say no to one of our questions, no to 2, no to 3. So significantly higher levels of errors, stress, and injury, even comparing those who say they work in real teams with those who say they don't work in a team. And we think it's because lack of clarity about objectives and roles leads to errors. You think your colleague is going to check a patient for bed sores. She thinks it's her colleague. The job doesn't get done. Errors are made and patients die. So if we look at the mortality data, what we see is that over time, 5% more staff in the acute sector working in a real team is associated with a 3% drop in patient mortality. This may seem a small amount. In England, using all of the data we have and taking into account all of the other confounding factors that might affect this relationship, we estimate that if we could increase the percentage of staff working in real teams from 40% to 65%, that's teams with clear objectives that work closely together and meet regularly to review their performance, that would be associated with, at a minimum, the prevention of 5,000 avoidable deaths annually. Team working is not simply a nice to have. It's fundamental to the delivery of high quality, compassionate, continually improving care. And so we need leaders to understand, my mother recommends this book, by the way, bottom right. We need leaders to understand what are the key principles of effective team leadership. And I'm not going to go through all of these because they'll be clear to you, but just a couple of points. Interpersonal conflicts in teams are a disaster for team performance. By the way, I didn't mention earlier, but one of the key issues about creating a positive environment is also recognizing that often what we see in healthcare organizations is senior staff, often medical staff, who behave in aggressive and intimidating ways. Those behaviors are as dangerous to patient care as medication errors because it means that staff are afraid to challenge them. So part of good leadership and positive cultures is making sure that we're dealing with those behaviors. In the short term, by coaching and feedback and senior leadership intervention. In the long term, through changing cultures in all our human resource management, organizational development, leadership development, curricular development processes associated with healthcare. We all have brief fallouts. It's the chronic interpersonal difficulties that really damage team performance. So it must be unacceptable to allow people to let their interpersonal differences get in the way of effective team functioning, which can affect patient care. And I've mentioned it already, but I want to say again that inter-team cooperation from our research is as important to organizational effectiveness in healthcare as intra-team functioning. We began a program of research back in the beginning of the 90s, looking at the functioning of healthcare teams under huge pressure, because we saw that so often in these organizations there is such pressure, such a lot of activity, frenetic activity. And we asked the question, what happens when teams under pressure stop and take time out and reflect and review? And what we found, and many researchers in at least 14 other countries, 15 other countries have found exactly the same, is that teams that take time out on a regular basis to review what we're trying to achieve, how we're going about it, are much more productive and much more innovative than teams that don't. So it's not that we're losing time by doing that, actually we're gaining time. And a recent meta-analysis, which is it's a meta-analysis of 49 separate studies. That involves bringing together all of the data from 49 studies and analyzing to see what it tells us. By Tannenbaum and Carasoli showed that teams that did regular debriefs and after-action reviews were on average 25% more effective and productive than teams that didn't. Even when they took out the top 3 studies in terms of effect sizes, it was still 22% more effective than teams that didn't. So it's really important evidence-based practice in terms of how we work in our organizations. And briefly, I want to mention another aspect of team working, which is working across boundaries, not just within our organizations, but across organizations as well. Drawing on the literature on intergroup contact and inter-organizational working, we conclude that there are 5 really important principles. First, there has to be, if we're going to take an area where, a region where our healthcare delivery requires that we combine with other organizations. We have to have a shared heartfelt vision of the difference we want to make to our communities. Second, there has to be frequent interpersonal contact between key people who are seeking to work across those boundaries. It's probably the most important factor. Third is we have to make sure that people are setting, in these systems, are setting long-term objectives, not just short-term objectives. So thinking about how we're going to make a difference to the mental health of people in our community in 20 years' time, not just in 2 years' time. And where that long-term goal setting happens, system leadership is much more effective. Shared models of conflict management and establishing a norm of always asking of the other organization or the other team, how can we help you so that your part of the organization or system can deliver for our communities. So that's absolutely vital and fundamental, I think. So the question is, I've gone through these 5 areas. I've talked about compassionate and collective leadership. How do we do that? Well, it seems that really the most powerful way we can do that is by making sure we've got leaders who are focused on those areas and modeling those behaviors. That means we have to have a leadership strategy for getting the leaders we need in place now and in the future. And I've had the privilege of working with our national regulator over the last 2 years on a very big program to help organizations develop such strategies. All of the tools to enable that are online, and they're free to download, they're open source, you can use them wherever. It's a 3-stage process of helping organizations examine their existing culture and leadership, and then design a leadership strategy which will deliver the leadership they need now and in the future, and then an implementation phase. The tools like compassion-based recruitment are described on the website with case studies. There are something like 50-odd tools available. It's an interactive web system. Many organizations in England and in north of the border are using them, and more organizations around the world are taking them up. We'd be delighted if you would use the tools as well. There's a community of practice that's been developed, and you can join the community of practice to learn about the successes, challenges, and difficulties of other organizations that are implementing this approach to changing culture via getting the leadership that we need in place now and in the future, and ensuring a pipeline of leaders. But I want to finish by where I started, by saying that I think that compassionate leadership at every level of our system is central to meeting the challenges that we face, because it's at the core of our healthcare systems, and that the potential impact is enormous if all of the people who work in healthcare in Ireland come to work every day and experience compassionate cultures, compassionate leadership. They take that back out into their families and their communities. And if all of the people who use the healthcare services in Ireland every 24 hours encounter compassionate care, they too take that back out into their families and their communities. The potential impact of our healthcare and social care systems upon our communities are enormous when we do it really well. And it begins with us in the way that we interact in terms of these 4 behaviors. But in order to have the resilience and the capacity to model compassionate leadership, we have to begin with self-compassion. Each of us, each of you, each of us has to first of all pay attention to ourselves, to understand the challenges that we face in our lives and in our work, to empathize with ourselves, to care for ourselves, and then to take intelligent, thoughtful action to help ourselves in order that we can be who we can be and stay close to the core values that give our lives meaning, like compassion, and enable us to have deeper and more authentic connections with all of those that we interact with. Thank you very much indeed. Thank you.